Well, welcome everyone. Welcome, welcome. Thrilled to have you here for the Bellos Lecture. Thanks for joining us today. It's great to see this crowd from all over. And those of you who also may be joining us by streaming, we will be able to tape this Bellos talk and be able to put it on the website afterwards for those who were not absolutely able to be here with us today. However, it is great to be together. So for those of you whom I've not had the pleasure of meeting yet, I'm the Dean, Ann Kurth. I just want to give you a bit of background about our program before I introduce our esteemed speaker today. So the Bellos Lecture is one of our signature events at the school here, and I know many of you look forward to this program every year. It's always a highlight. Sybil Palmer Bellos was an extraordinary nurse who was best known for her work with immigrant families in New York City. She graduated with the class in 1927, which was one of YSN's earliest classes. A few of us, including Helen Varney, I'll just mention, we're trying to put together a timeline of the school that we're going to be able to put up on the walls around here, and so you'll see circulating versions of that. But it is really nice in having delved into the history of the school to really think about our origins, which I will share with the Rear Admiral. We were actually founded by Rockefeller Foundation funding when they did the Goldmark report to look at public health nursing originally. They broadened it later, but it was about public health nursing. And then we became, probably the country's first academically housed school of nursing. So, we really have this proud history here at the school of service to people and communities, as well as intellectual contribution to nursing as a discipline, right? An evidence-based discipline that forms the foundation of health systems everywhere. So each year, it's our pleasure to feature a remarkable individual who follows in Sybil's footsteps, someone who expands the frontiers of healthcare and strives to bring better health to all people. So with that in mind, we're really thrilled to welcome Rear Admiral Sylvia Trent-Adams as our 2019 Bellos speaker. Dr. Trent-Adams became the Principal Deputy Assistant Secretary for Health in January of this year, and before her current role, she served as the Deputy Surgeon General of the U.S. Public Health Service. As Deputy Surgeon General, Rear Admiral Trent-Adams was an essential advisor to the Surgeon General, helping support a variety of critical issues, including efforts to combat the opioid crisis, which remains a current national crisis. Most recently, Rear Admiral Trent-Adams' lifelong service was recognized with her election in 2018 to the National Academy of Medicine and the National Academies of Practice. She has held several leadership positions in health and human services, working to improve access to care for poor and underserved populations. As both a clinician and an administrator, she's had a direct impact on building systems of care to improve public health for marginalized populations, domestically and internationally. She's done it all. She's done Ebola, she's done opioids, she's been everywhere. As we think about nurses like the Honorable Lauren Underwood, who was recently elected, becoming engaged in political leadership, I thought it was kind of telling to note that early in her career, Dr. Trent-Adams completed 2 internships in the U.S. Senate. Very strategic. Dr. Trent-Adams received her Bachelor of Science in Nursing degree from Hampton University and a Master of Science in Nursing and Health Policy from the University of Maryland, Baltimore. She also earned a PhD in Public Policy from University of Maryland, Baltimore County. Dr. Trent-Adams became a Fellow of the American Academy of Nursing in 2014. She received a Meritorious Service Medal for her leadership during the Commission Corps response to the Ebola outbreak in West Africa, and the Surgeon General's Medallion for her time spent as Acting Surgeon General. In 2017, she was the recipient of the International Red Cross Florence Nightingale Medal, the highest international honor bestowed upon a nurse. Please help me welcome Rear Admiral Sylvia Trent-Adams.
Good afternoon, everyone. I am so excited to be here. I want to thank everyone for your attention this afternoon, and I want to thank you for the opportunity to join you. To Dean Kurth and the Yale University administration, thank you so much for the invitation and the warm welcome. And to the faculty and staff, hello, good afternoon, and thank you for your attention today. This is always an exciting time for me to come back to my roots in nursing, because there's so much that nurses do that's often unrecognized, and we do play a significant role in bridging the gap for health disparities. And I want today to spend some time talking about how those 2 areas collide and how I have been able to be involved in some of those things in my career. So first, as you can see, the title of my slide today is for this afternoon is Bridging the Gap, Addressing Health Disparities. And I'm going to hope I get this right. Okay. And as I do in all presentations, I have to say that I have no financial disclosures that would be a potential conflict of interest with this presentation. Now, my objectives today are to talk about defining the barriers of health and healthcare, discuss the impact of social determinants of health on communities, identify innovative models of care at the community level focused on comprehensive community-based care. And I want to talk first, let me go back a little bit, because I want to talk about the U.S. You know, in the United States, we've made great strides in improving health of our nation, and especially over the last century. Precision medicine, vaccine research, drug development, amongst others, have impacted our efforts to improve chronic illnesses. People are living longer, but where we fall short is ensuring that optimal and equitable health across all sectors of our population can be achieved. Today I will discuss some of the factors we need to address in order to achieve a level of success. And through these objectives, I hope to accomplish that. So on this slide, in the last 2 years, we've seen a decline in life expectancy across the United States. Inequalities of life expectancy are occurring among counties that are large and increasing over time, and specifically in underserved populations in rural communities, as well as with subpopulations of many communities across the nation. The difference in life expectancy between the lowest ranking county and the highest ranking county is 20.1 years. Unfortunately, in this country, your zip code dictates your health outcomes more so than your genetic code. Today I will discuss some ways we're trying to change this paradigm. But let's begin the conversation by discussing some of the barriers to health and health care. And I want you to note that I said health and health care because they are two distinctly different things. As we discuss communities and methods for improving our overall health as a society, we need to address the current barriers to health and health care and how we, as researchers, as clinicians, and public health professionals, can overcome some of the health disparities and health challenges plaguing our country. There are many structural barriers, such as transportation, childcare, geography, social barriers. Many of these are related to the systems in which we employ to provide and deliver health and healthcare services. Now, these system barriers are very much real for those people who are in the policy realm, but they also they affect the frontline providers as much as they, in fact, impact the policymakers. Regulatory barriers impact the way in which we deliver care. Regulatory barriers dictate what you can and can't do as a clinician. Many states, how many are aware of the Nurse Practice Act as being a major challenge? And also as we look at providing MAT, medicated assisted therapy for opioids, buprenorphine, looking at who can provide certain types of medications in structured environments are directly driven from regulatory and statutory policies. Okay. So looking at health disparities versus healthcare disparity, and I want to talk about the differences here. We must first define these terms. Disparities in health and healthcare are related but not synonymous concepts. A health disparity refers to a higher burden of illness, injury, disability, or mortality experienced by one population group relative to another. A healthcare disparity typically refers to differences between groups in health insurance coverage, access to and use of care, and quality of care. More specifically, health and healthcare disparities often refer to differences that cannot be explained by variations in healthcare needs, patients' preferences, or treatment recommendations. Several related items, such as health inequality and health inequity, are also used interchangeably to describe differences as socially determined and or deemed to be unnecessary, avoidable, or unjust. So the differences between having access to care versus having access to insurance are very, very different. Now, I can tell you from traveling across the country and working with a lot of underserved populations, there are many people, the working poor, who may have health insurance provided by their employers or that they buy into a plan, but there may not be a provider who can meet their needs within their geographic area, or there may not be a provider in their plan. There may not be a provider who provides the specific services in their plan at a cost that they can afford. So therefore, there are very many policy changes that need to happen in order to ensure that everyone has access that they can afford, and when they have access they can afford, they have a provider who can provide that level of care. Okay. So I want to talk about factors associated with health disparities. So what are some of the factors that contribute to disparities? This is kind of a complex issue that we often struggle with, and there are so many complex and interrelated set of group, individual, provider, health system, and societal and environmental factors that contribute to disparities. And these can exist in health and in health care. Individual factors include a variety of health behaviors from maintaining a healthy weight to following medical advice and following up for appointments or follow-up to care that's needed to maintain one's care and health status. Provider factors encompass issues such as provider bias and cultural and linguistic barriers to patient-provider relationships and communication. How healthcare is organized, financed, and delivered also shapes disparities, as do social and environmental factors, such as poverty, education, and proximity to healthcare and the neighborhood or their safety. So why do healthcare disparities matter? Disparities in health and healthcare matter because they not only affect the groups facing disparities, but they also limit the overall improvements in quality and the cost of care. And the healthcare quality for the broader population is a result of unnecessary cost. So, as you know, in any community where you have a high level of uninsured individuals, where do they typically access care? In the emergency room. Where is the most expensive place to access care? The emergency room. Because typically it involves either someone walking in with a condition and or illness that is exacerbated to a point that it costs much more to treat it and cure it or resolve it than it does to prevent it. So these are some of the challenges that many states and many communities are facing right now. So by having many barriers to access and barriers to addressing the disparities in healthcare and also in health systems, there's a social justice component of this as well. But for improving the health care of all Americans, we have to achieve improvements and achieve some level of quality, a high level of quality at the optimum, to achieve a high level of access to population health care. Moreover, health disparities are costly. One analysis estimates that approximately 30% of total direct medical expenditures for Blacks, Hispanics, and Asians are excess costs due to health inequalities and inequities. So what are the social determinants of health? I want to talk about how education, economic stability, food, health status, and healthcare systems, neighborhood, and physical environment can affect the health of one individual community or an individual. These are indeed the social determinants of health. I want to give credit to the Kaiser Family Foundation. This model was something that was released several years ago, but it's my go-to because it is the best depiction that I've ever found that accurately and appropriately define how the social determinants of health impact the many variables that are in these different categories. So as we look at addressing these gaps, we need to address the gaps in ways that will improve population health through health care reform, such as the Affordable Care Act, or many of the other models that have been established through many of the state programs. Massachusetts is a state that started very early looking at health care reform. But Massachusetts is very, very unique, and I'm often reminding people when we have these conversations, but what about Massachusetts? Massachusetts is very special. Massachusetts has the following: a very solid high tax rate, so their state taxes cover a lot of health care. You also have a wealth of health professionals training institutions. You also have a lot of community health centers for free and sliding fee scale costs for care. And you also have a lot of nonprofits who provide free care to individuals who are uninsured or underinsured. That is not the case in every state in the United States. Massachusetts also made health care a priority. That is definitely not the case in a lot of states. What has happened in Massachusetts is now considered the gold standard for some policymakers, but I would venture to say that Massachusetts is not necessarily the gold standard. It is the best that we've been able to accomplish as a state is concerned in the United States. But it is a place for us to start looking at as a model whereby health care can be made available to all citizens and all individuals who need care. But what is being done to address the gaps with the social determinants of health? Improving population health, healthcare delivery system reform, and also looking at the healthcare delivery system as a model. We need to expand the scope of services to meet the needs of individuals and populations. One of the things that I often talk about when I do this presentation is that most people don't understand the combination of health care, prevention, health outcomes, and saving money. Now, the economists scratch their heads and go, well, we need data. So they'll always look at actuarial data. And see, I was at CMS yesterday, and we had these robust conversations about how to calculate risk, how to calculate what's the best cost for a service. And it's all for naught if you don't look at the real cost. And we are one of those cost factors that never gets calculated into the real cost of providing care. Nursing services have to be, at some point, factored into the unit cost of how care is delivered. It has to be calculated into the need for public health nursing at the community level to truly get to a prevention model that would be sustainable, cost-effective, but more importantly, the main factor in how people are able to stay well and not get sick. That's my public service announcement for public health nursing. Now, I'm going to do my best to stay on script because Sylvia's a nurse, regardless of being the P-dash. I'm still a nurse, and so Santiago, forgive me. There are a lot of things happening right now within the Department of Health and Human Services. As you heard earlier, yes, we're spending a lot of time on opioids. We have a lot of priorities that are focused on the social determinants of health, but not all of it is determined social determinants of health. So, in some cases they say you have to flip the script depending on who you're talking to, and I learned that on the Hill. My kids tell me that there's a vernacular that I need to learn how to incorporate into my daily language and my vocabulary. My verbosity of terms from a health policy world doesn't work with the millennial generation. So I'm going to try to do my best here to not use so many words to communicate to you. So flipping the script means that we have to change the way we say certain things to make sure people can understand us better. They need to understand the value of nursing, understand the value of prevention, and then understand the value of making sure that everyone has access to care. Right now, if someone was to articulate the real cost of not having children immunized for measles in the state of Portland, Oregon, in the state of Oregon, and the state of Washington, they might pay attention. But prior to this, we've not been able to get public health messaging on the forefront or on the front page of the New York Times and Washington Post until there's a crisis. And that has to stop. Now, within the Office of the Assistant Secretary for Health, I'm going to tell you, I have a great boss, and he drives me crazy some days because he has more energy than the ever-ready bunny. Admiral Jawar is very unique in that he understands the need for change, but he also understands how to be a change agent. He understands the importance of having people who understand the real problem on the front line. And just this week, I think it was 2 days ago, we were on a conference call, and he acknowledged that the most important provider in the healthcare delivery system was nurses. Now, part of that was because he had, a bunch of Admiral nurses sitting in the room with him. I happened to be taking the call virtually, and I said, "Sir, I would never contradict you when you are right." So we have a lot of advocates for nursing and for prevention and healthcare delivery system reform within the Department of Health and Human Services right now. I didn't know a lot of the people who were coming in as the change of I've lived through, let me say this, I'm going to date myself. I am in year 32 of uniform service. Yeah, I know I don't look like that. It's a good gene pool. We nurses can do that. But year 32, I've lived through quite a few administration changes. So right now, I do just what I would do in anything else. Patients come and patients go, right? So you assess a problem, you get your nursing diagnosis, then you develop an intervention, and then you evaluate how effective you can be. I use a nursing process in every decision that I make, regardless of the level within the organization. So that's what I need you to do every single day when there's a change in professor, change in class, whatever you need to do, just invoke what you already know. It's that simple. So when Admiral Jawar came on board, I basically had to size him up, so to speak. So what is this guy really about? But I didn't get a chance. He walked into our office in the Office of the Surgeon General and said, he looked at me and he says, "Oh, you must be Admiral Trent-Adams." I said, "I am." He said, "Your reputation precedes you." And I didn't know what that meant. I just kind of, just said, okay, I'll see how this goes. Everything that I've asked him for related to nursing, social determinants of health, prevention activities he has supported wholeheartedly. And I will tell you, not everybody in the department always agrees with him, but he usually wins. So, moving on. What are we doing around the social determinants of health? You know, what's being done now is to look at how we identify gaps and using this opportunity to improve population health and healthcare system reform, but also looking at what's already in place. Looking at the Affordable Care Act, which is constantly under scrutiny, the National Prevention Strategy, which is managed out of the Office of the Surgeon General, and expanding the scope of services to meet the needs of individuals and populations. So what does all this mean? We have a roadmap. In the Office of Assistant Secretary called OASH, and bear with me, I'll use lots of acronyms today. If I say something you don't understand, you can stop me. Within the Office of Assistant Secretary, these are some of the programs that we manage. All these programs are intended to look at the social determinants of health, look at a prevention model, look at how we can redefine, reshape, and reinvigorate our healthcare delivery system to better meet the populations that we serve. And that is within the United States and abroad. Because I didn't know this until probably, I think it was in 2013, the first time I went to the WHO to represent the USG as part of the Chief Nursing Council. Someone said, well, what is the United States going to do? And I said, well, no, what are you going to do? They said, no, what is the United States going to do? And it took me probably 3 seconds to realize, oh, she wants to know what we're going to do because there must be some value to it. And as I sat down in my seat, I realized that this was a huge opportunity, but a significant responsibility. Because when I sat in the seat beside Marla Weston, who was at the ANA at the time, and on this side was Pam Cipriano, we were the three go-tos. I was representing the United States as a chief nursing officer for the Public Health Service, which by default becomes a chief nurse for the United States. And together, the three of us had an opportunity not only to comment and, how do I say this politely, have intense fellowship with some people about some things that weren't necessarily in keeping with the spirit of moving nursing forward for the 21st century. And we had a great time discussing philosophical views and philosophical beliefs. But when we came out of that room, we all agreed that we have to stand together, 30 million strong across the world and 3.3 million strong in the United States, because wherever you are going to make change, you're only as strong as your weakest link. Nursing cannot be that weak link. And I keep reminding the physicians that I work with, as well as the pharmacists some days when we're talking about opioids, keep it up. You're going to wake up the sleeping dragon, because we're 3.3 million strong. And when we do decide to come together and coalesce around central theme, central ideas, and one agenda, not 50 different agendas across all the states, but one agenda, we will be the dragon that will be ruling the roost. But that's, again, a public service announcement for nursing. So these are some of the responsibilities in the Office of Assistant Secretary for Health. And we do spend a lot of time talking about how do we make the system better? How do we improve health outcomes? And what are we going to do for the next 10, 20, 30, and 50 years to make sure that our children who are being born today will meet the medical as well as the physical guidelines to be able to qualify for military service. We are in a crisis right now because 70%, 7 out of 10 youth between the ages of 17 and 25 cannot medically qualify for recruitment into the military. Now, if that doesn't scare you, I don't know what would scare you. And primarily, there are three different reasons. Obesity, so they don't meet the weight requirements. There is a mental health condition that disqualifies them, or a criminal record. Those are the top three. So 70% of them do not qualify. So it is crazy. You're absolutely right. It is crazy. But we're working to move the needle forward in how we can address some of the priorities within the department as well as within the communities. So what are some of the things that we're doing in OASH? We have some initiatives that we've been working on for the last 2 years, but some of them are carry-ons from the previous administration. So within the area of health disparities, we're working to develop the Office of Minority Health programs that serve as a catalyst to new framework for change. And this means that we're creating new innovative ideas to reach minority populations that have been left out of the healthcare delivery system. We want to look at language, culture, and also recruiting providers who look like the community, talk like the community, and can be an invested stakeholder in that community to be able to serve those that they represent. And within implementing a public health turnaround teams, focused on zip codes suffering the worst health inequities with the Commission Corps. And I'll talk about that in more detail. Improving the availability of CPR. There's no national registry of CPR, but when we did a survey, CDC did a survey probably 10 years ago, they noted that the communities that were most likely not to have CPR were communities of color, rural communities, and communities with high levels of violence. So those are the communities that need it most, because where do we see the largest disparities of cardiovascular disease? In minority communities and in communities with high violence. We want to develop exemplary initiatives for minority and underserved communities. So when I say underserved communities, it includes minority communities, but minority communities have been pulled out because of the specific focus around health outcomes and health disparities. Moving on here. So moving on with our new initiatives around infectious diseases, we want to reduce the new cases of HIV by 50% within 5 years. We just launched the 10-year plan to eliminate HIV. That is receiving $2 billion over the next 10 years. And we've already stood up several of the teams at CDC, NIH, and HRSA. Can you believe it? The federal government coming together to talk to each other? It's quite amazing. But this will be a continuation of the HIV strategy, the National HIV/AIDS strategy, the NHAS, from a few years ago. But what we're doing specifically around HIV is looking at those communities. There are 48 counties that have the highest number of new cases every year. So we're doing teams, staffing teams in 3 regional offices with Commission Corps officers, and we're calling it Change the Map. And these are PACE teams, which have been developed through the Commission Corps, and I'll go into more detail about how PACE works a little bit later. I want to talk about interventions there. But we're sending concentrated efforts to 3 regional areas, and one will be the Atlanta, Georgia area. We have a regional office, and we call it Region 4. Atlanta, Georgia. The Southeast has the highest rate of undocumented HIV in the country. We're also looking at Dallas, Texas, because we have the highest rate of Hispanic new infections in Dallas, Texas. And in LA County, in Los Angeles, California, is where the 3rd team will be. And they will be specifically looking at homeless, youth, HIV infected, and also those who have comorbidities around the opioid epidemic. And then incentivizing adult vaccinations through reimbursement reform. There's been a lot of work with the National Vaccine Program Office and the Office of the Secretary, which we also manage in OASH, to look at how do we best give advice about reimbursement reform for not only insurance companies, but self-insured providers, such as large corporations who insure their own employees. And develop a national plan to combat STDs. I didn't know until a couple of months ago that we've never had a national strategy or a national plan around STDs. So this is what we're doing around infectious diseases. And meeting physical activity guidelines for all Americans, developing a national plan for youth sports participation and physical activity targeting underserved communities and girls. There's a lot of data about physical activity in girls. You know that girls seem to drop out of sports and other activities related to physical activity in middle school. So what is it about middle school? For boys, it seems they disengage from STEM programs in middle school, and girls seem to drop out of the physical activities. So there are a number of programs within the Office of the Assistant Secretary that are focused on getting girls involved in sports. Girls on the Run is a big program that's being supported nationally and also trying to take that internationally. And working with CDC to do more messaging around healthy weight and healthy body image for girls, and helping them to understand the connection between diet and exercise. Okay. Improving cardiovascular mortality. As we looked at the National Cardiac Arrest Registry, we know that there's a need to double the survival rates. We know that we can double the survival rate of individuals who have access to CPR when it's witnessed by someone who knows CPR, and will increase the likelihood that they'll be able to get help to get to hospital cardiac care. Chronic kidney disease, HHS-wide, we're doing a comprehensive plan to improve the outcomes and the cost of chronic renal failure and end-stage renal disease. Many of the dialysis companies around the country are for-profit. Many of them target underserved minority populations. And the rates are significantly higher in some parts of the country than there are in other parts of the country. There's been no gold standard for identifying the standard of care for renal dialysis and outpatient care for many places within the U.S. So this HHS effort is going to hopefully raise awareness of kidney disease, increase awareness around the need for transplants, and also identifying reimbursement rates that are commensurate with the provider supply and the service providers within a given geographic area. There's no reason why there should be a threefold increase in cost in Mississippi for dialysis care than there is in New York City. And we do see some price gouging in some of those cases. And using digital determinants of health to help us to develop a better legal and ethical scientific frameworks to fully leverage social media for public applications. And this is really, truly interesting. The Surgeon General, Dr. Adams, Jerome Adams, bless his heart, he loves to be on social media. So some of us are more challenged because we're so involved in policy, we're not always out and about doing all the social media, but he lives and dies by his social media contacts. He literally, part of our staff meetings used to be focused on how many tweets he had and how many retweets. But it's important to understand because the population that he's trying to reach are young people who need information. And we have to all be able to embrace the digital age. But not only do we need to understand how to use it, we need to know how to promote it with our patients and promote it within the communities where we live and where we work and pray. And the reason I say that is because there are a lot of people. And I will tell you, my mother does not have internet access in her house. It drives me crazy when I go home and I can't get a signal from my phone. There are still people who use hard copies of everything. And we need to understand that the fastest growing population in this country are the baby boomers. Some of them are digitally connected and some are not. And we still need to live in that world where we are able to meet the needs and demands of both. Now, is it okay to expect people to have an email? In some cases, yes. But in rural America, where I grew up in Appomattox County, Virginia, not everybody has high-speed Wi-Fi. That high-speed cable and Wi-Fi don't exist in some of those places. And if there's a good rainstorm, it'll wash out whatever landline exists. So we need to be very respectful of this when we're designing programs and developing policy because it does impact access. I'll tell you a little story. A couple of years ago, we had a crisis in the Indian Health Service. And I got a call from Secretary Price. He said, Sylvia, I need you to meet us at 3 o'clock today. I said, okay. So I go downstairs and meet with him and the Chief of Staff. They said, we need you to take a trip for us. I said, okay. We need you to go in and do a clinical assessment of this facility and figure out what the heck is going on. I said, okay. And I said, well, where is it? It's in South Dakota. Okay. And I'm thinking, South Dakota? Okay. Well, I've got what's on my calendar for the rest of the week? Okay, well, just let me know what we need to do. He said, so by tomorrow, I need you to go up there. I said, tomorrow? Tomorrow. Talk about being able to leave D.C. and get to Baltimore, Washington, to the BWI airport and stop in Columbia and pick up my clothes to get on the plane to go to South Dakota that night. Was one of those experiences where you say, nurses can do anything. But when we got to Pine Ridge, South Dakota, it was a reality check for me because of poverty, the isolation, the weather, and just traveling long distances to get from point A to point B for basic care was overwhelming. This was one of those times in your career you go, okay, I didn't even know this existed anymore. But there are parts of the country that still are very isolated. They have high need. We had a suicide cluster there a few years ago, and we recruited mental health providers to come up, and they all stayed maybe 3 months in 3-month increments. You know anything about taking care of providing good care to patients and things around things like mental health, suicide prevention, and drug overdoses? You need to have a relationship with them. You can't build a relationship and rotating people in every 3 months at a chunk. So we need to make sure that we needed to make sure that we were building a sustainable model of care that was going to be someone who was going to be there, be committed, understand the needs of that community, and give them some of their time and space so that they would not continue to have this cycling, this in and out process of being able to meet their needs. And I remember being in the conference room with tribal leaders, hospital administrators, and patients. And what I took away the only thing I remember from that blur of an afternoon was this. The patients wanted to be heard, but the staff were so burnt out, they couldn't hear. The tribe was so focused on things that were political that they couldn't hear. And we really need to be there at that point in time to kind of be the neutralizer. And I remember at the end of that day, I said to the tribal chief, thank you for allowing us to be here, courtesy and respect, honoring their traditions. but we have a bigger problem than you think we have. And what I need you to do is to help us figure out who needs to come to the table in DC to be able to communicate what the patients here are dealing with, and then figure out what the next step should be. Because right now we're not going to get anywhere if we don't all kind of check our egos at the door and start to understand that we're not here for our career's sake. We're here because we need to build a system of care for these patients. And he looked at me and he said, "I like you." I said, I don't know what had been happening there, but I sensed that he felt disrespected by the team of people that preceded us. But on our team, we had 2 nurses, a hospital administrator, and someone who was there to strictly be the advocate for the tribe. And I think having someone that was not coming from senior leadership in the department, having the deputy secretary, chief of staff, whoever, come was the best decision ever. Because I said, I stand today, I'm not Admiral Trent-Adams. I'm not, the Deputy Surgeon General. I'm here as Sylvia, a nurse who wants to help. And that kind of lowered everybody's expectation. But we were able to have an open dialogue about what needed to happen there. And that's how we need to engage with our populations, whether it's digital, whether it's addressing new priorities, or standing up a new initiative to stabilize a crisis in a healthcare delivery system. Now, we're also addressing the opioid crisis. Now, as many of you may know, we are in free fall with the opioid crisis and no end in sight. We're seeing pockets of the country. Ohio is getting ahead of their curve, but whatever we're doing with supply and demand is not working, and we need to figure out how best to address the needs across the entire delivery system. I want to talk about our healthcare delivery system and how services are delivered, because patient-centered services have to be the way of the future. We've been doing a lot of case management. We've done innovative models of care delivery. We're also invoking telehealth, and we're using electronic health records. And the use of data for planning and design for team-based care they're significantly important to building a solid healthcare delivery system. But we cannot do it if we don't have providers and patients on the same page. Policymakers are great at coming up with great ideas, and I can say that I've been in the room with people who sound like me, look like me, but we're not always right. And if you build it, they will come. It's not the way to approach underserved populations. You have to hear what the patients need. And we also are working on a number of initiatives around impact on community, doing evaluations that give us real-time data on how service delivery models are working, also looking at intake and output for who's coming in, who's leaving the healthcare delivery system from a patient standpoint, but also as a provider standpoint, from a provider standpoint. Okay. There are a number of models that have been proven to be very, very successful. Now, I'm a little biased on this because I grew up in the Ryan White HIV program. But the Ryan White HIV program has been able to develop a model at the federal level. You have the administration of the program, which by statute requires them to engage community at the state and local level. And it also requires that, by law, community participants need to be a part of all decision-making processes. So in the large cities, we call them eligible metropolitan areas, EMAs, and many of you may be familiar with this, you have to have an advisory board. And that advisory board is responsible for making decisions on setting priorities of how the money is spent. So to do that, you have to have communities identify stakeholders. Patients can have to be involved in the decision-making, providers, and all different types of organizations, insurance providers. They have to be a part of the decision-making process. Now, when we look at what we're doing to improve access to care in some of our most underserved and rural areas, and also those areas that have what we call hot zones or high-impact areas, we've been using Commission Corps of the Public Health Service, so folks who wear this uniform. And by the way, if anyone's interested in joining us in this uniform, we're always looking for good nurses and docs and dentists. But we developed a PACE initiative, and it's prevention through active community engagement teams. And these are the teams that are being placed in those 3 areas, Atlanta, Dallas, and Los Angeles, to take on the opioid crisis. And what they will do is provide very concentrated efforts around decreasing the number of new infections and definitely decreasing the number of overdoses. So the Ryan White Care Act program, as I said, in 1990, it was enacted into legislation. It created the Ryan White program. It's administered through HRSA. It has also the model that helped to do a transition of services under PEPFAR. So the PEPFAR is the Global HIV/AIDS program funded out of the State Department. PEPFAR does a financial transfer from the State Department to HHS so that HRSA could develop a nursing education partnership initiative in sub-Saharan Africa, and they also developed a medical education partnership initiative in Africa. And the goal is to provide quality and to improve the quality and availability of HIV services across the domestic population for the Ryan White program and globally for the PEPFAR programs. So just a few facts about the Ryan White program. 73% of the population are ethnic minorities, and we have 62.8% live below the federal poverty level, and 44.4% are over the age of 50. That is one of the fastest growing populations is the elderly, but we say over 50. And 84.9% of the Ryan White clients are virally suppressed, which is phenomenal because the average population, the general population, according to CDC, is between 48 and 52, depending on when you look at the data. So they've done a phenomenal job in being able to improve viral suppression. So the Ryan White framework is a comprehensive framework. It is the public health approach to providing comprehensive care and services. That system of care provides an opportunity for everyone to be involved in the care delivery system. It involves service delivery, policy, assessment, capacity development, and quality. And what we do in that context is our goal is to reach optimal health care and health outcomes for everyone. And we know that we want to make sure that low-income people living with HIV receive optimal care and treatment regardless of where they live. A third of the programs in Ryan White are in rural communities or serve rural communities. Many of them are statewide initiatives funded out of either state or national program, but the vast majority of those rural programs have access to services for Ryan White that don't exist for general primary care, for the non-HIV infected population, I should say. So I wanted to give a little bit of a background on HRSA. Have anyone ever heard of HRSA, the Community Health Center program? Great. The HRSA's community health centers serve more than 27 million patients and about over 1,400 to 1,500 centers, and there's over 12,000 service delivery sites across the country, including Puerto Rico and USVI, Guam, Micronesia, and Saipan. So the health centers provide a variety of HIV services. 2 million HIV tests were conducted annually. Every year, it runs between 2 and 2.5 million. More than 165,000 patients with HIV receive medical care services at health centers. The community health centers have been one of the biggest customers for Ryan White. I think about 2/3 of the community-based programs within Ryan White are co-funded by Ryan White, community health centers, Maternal Child Health Bureau for the Title V program, and also received Title X under the Office of Population Affairs for the Planned Parenthood. And then we want to make sure that we link everyone to care through HIV prevention services and PrEP. Under Ryan White authority, you cannot provide services to anyone who is not HIV infected or at high risk for. You can test those who are at high risk, but you cannot provide them with PrEP. But the community health centers have broader authority, and they can provide PrEP. So if they're co-funded with Ryan White and community health center funding, it increases the likelihood of them being able to get access to PrEP. So here is the care continuum for Ryan White. I love this model. Like I said, full disclosure, I'm a little biased, is that the goal of Ryan White is early intervention. And early intervention is broadly defined. It's wherever you come into the system, you can get access to care. And there are a series of steps for someone who has HIV, doing their initial diagnosis and when they're getting tested and being counseled, that they get diagnosed with HIV, then they get linked to care, they're engaged or retained in care, they get on their antiretrovirals, and the goal is to achieve viral suppression. This model is the model for all the Ryan White programs, whether it's Part A, B, C, or D. This is the continuum that we use within that framework. Now, I talked about PACE, and PACE is one of the things I love PACE because it is so innovative, it's creative. PACE came out of a need for substance use and tobacco training for schools schools, elementary, middle, and high schools. And there were a number of needs assessments conducted across the country. Commissioned Corps officers volunteered to be a part of PACE. In their off-duty time, they're nurses, doctors, pharmacists, engineers, environmental health officers. They come together, they create their teams, and they identify schools at high risk for tobacco, substance use, mental health conditions, or obesity, low rates of activity, and they target those schools, and they've developed curricula, and we've leveraged the expertise of Commissioned Corps officers at all levels of training, and they've built these curricula specific for the schools and in the language of the communities that they serve. So they've gone out, I think all 10 regions now have teams, and each of these teams work with within partnerships with the schools, as well as housing authorities. They work with the state and local health departments to build a program that meets the specific need of that community. Now, and I'll say that what you see in California may not be what you see in Washington, D.C., and it may not be what you see in Alaska. But whatever you see in those communities or within those teams is what's been developed and designed specifically for that community. We had high rates of tobacco use in some of the schools, the high school students, including traditional tobacco as well as vaping. In Alaska, and the teams decided we're going to do an e-cigarette initiative, and that's how we were able to get training out to the schools, elementary, middle, and high schools. And the benefits is that these officers live in the communities. They work and they live, and they're assigned to the health centers or large medical centers where these communities are located, and they're able to build trust with the local communities, and they have a vested interest in improving the health. It also increases the visibility of the Commissioned Corps because many people don't know who we are. Just on the way here, someone thought we were an airline pilot in the airport this morning. They thought we were Navy on the shuttle to get to the rental car. And then I don't know what the guy thought I was when he passed me on the seat. He kept saying, "Thank you, thank you, thank you." But he says, there's a lot of medals. And I just said, "Thank you." I'm in the Commissioned Corps. He said, "What are you? You're like," he said, "What?" He said, "You're a pilot?" I said, "No, I'm a nurse." He says, "Wow, okay." And the other thing that PACE does is it helps to develop the leadership skills. They're speaking to large groups of individuals, developing relationships, and improving their emotional intelligence. But it also desensitizes them to the unknown because in many cases, they don't know what the communities need. They live and work in these environments, but they have no connection to the community until they start to work with the schools, work with the health departments, so that the health departments are saying, you know, we have high rates of teen pregnancy. Well, let's figure out how we're going to do this. So they usually find the right providers to be able to come in to give them advice and counsel. CDC, FDA, and NIH will look at the curricula for them, validate them, test them, and then give them some evaluation feedback for before they start to implement their interventions within the community. Okay, Santiago, I got you. I see that look she gives me. So I'm coming to the close now. So, you know, these are, I always like to give take-home messages at the end of my presentations, and it's because I want you to have something about the perspective that I'm trying to share with you. This is just Sylvia talking. This is not Admiral Trent-Adams, this is not HHS, but this is what I will say. Based on my perspective, we need to invest more resources at all levels, the federal, state, and local, to provide access to quality care for all. We need to shift from the sick care model to a prevention model. Because if we don't start to take prevention seriously, we'll be having this conversation 20 years from now yet again. Health and health care are not just clinical care. We need to all remember that the determinants of health play a key role in our healthcare delivery system. The vast majority of health care and factors that associate health happen outside the tertiary care system. It happens in the community. So that's where we need to be, and that's where we need to be investing our resources. Addressing the social determinants of health is everyone's responsibility. We all have a role to play, and we all have a vested interest in making sure that our communities and our country and our states, that every place that we can see that there's grass, it's called the United States, we have a vested interest in it. And I want to close with a quote from Justice Sonia Sotomayor. And she says that, and I quote, "I am an ordinary person who has been blessed with extraordinary opportunities and experiences," end quote. And I think that defines also what we as nurses are able to do. Not everybody can be a nurse. I'm convinced of that. I had two cousins who tried, but that just wasn't their thing. I'm thankful for law school because they're wonderful lawyers. But, you know, being able to be a nurse is truly a treasure. We can connect with people on a level that others can't. They trust us. We are the most trusted profession. We are the most revered profession when it comes to having that social, that human interaction. I think that our contribution to humanity and society is tremendous. We have to take responsibility for our own space and our own place in the community, but also in healthcare leadership, and that includes policy. So I hope that each one of you will find your voice and be able to contribute to the decision-making and the policy-making as it relates to our profession, the future of this country, and the future of the health and safety of our youth. Thank you. So, I did okay? Okay. She has this little teleprompter with time on it, and so she knows I get excited about nursing and public health. But I did want to leave a few minutes for questions if there are any. Yes, ma'am.
Hi, I'm Beth Beckman. I'm the Assistant Chief Nurse Exec for Yale Health System. And my question is around the opioid crisis. And what you see, I heard you say we aren't making the progress that we'd like to make, but what can nurses do to make a difference?
Okay. The opioid crisis is real. I think that the one thing that I've learned from this is that education is critical. Education is one of the most important factors around prevention. And let me unpack this for a minute. There are many people who don't even know what an opioid is. So friends and family, your children's teachers, their friends, your church, your synagogue, your mosque, wherever you go, where you find space that you can have a voice, you need to share, first of all, what is an opioid? The basic 101 about the opioid crisis and how we got here. Understanding that everyone deserves a right to have care, and we need to also make sure that we're educated about what we can do to prevent individuals from first misusing substances, but then if they are misusing, how do I get them the help and care that they need? And then how do we prevent someone from overdosing? If we were in the 80% of overdoses are happening in the community. They're not happening in the tertiary care facilities. They're not happening in outpatient clinics. It's happening in the community. So the naloxone advisory that the Surgeon General released last spring is critical for us to understand that people in the community need to have access to naloxone. I know providers are having some difficulty with this. There's a standing order at every pharmacy, I think now, in all of the states. Now that we got the last two on board, all 50 states and territories have a standing order. You can go to any pharmacy and request naloxone. Now, unintended consequences. The nurse who in New York who was notified by her health insurance company that they were going to drop her because she had a prescription for naloxone. And so when they started to go through, all of her history of prescriptions and so forth, they found this prescription for naloxone. She said, I'm a provider, and I'm a nurse practitioner. I work in a clinic and a substance abuse clinic, so I need to have naloxone in case someone overdoses. Well, I'm sorry, but that puts you at high risk. So those are some of the things we need to be aware of, but also make sure that we are education, prevention, communicating with everyone that we can get our hands on, and also raising awareness around us around the policy implications of the opioid epidemic. We're making some progress, but supply and demand is just vicious, and we're not even at the tipping point yet. Some areas have, start to, see a flattening out of the plateauing, but we're nowhere near the end of this epidemic.
Right. Thank you for being in the position you're in. We're blessed to have you. Your presentation was very revealing for your work, so we need more people in office just like you.
Well, thank you. Thank you very much. And being career, I can say all kinds of things about, the history. Well, we did that before, it didn't work, but here's why it didn't work. And people are starting to listen to that. And I more often than not, I'm still often the only something. And I want to say this, can I just, for a minute, let me just say this to nurses. Okay, so nurses. People who want to be nurses. There are things that are going to come your way that are going to discourage you, that will beat you down, just shake yourself off, knock the dust off, get back up, and go at it again. If I could tell you how many people in the course of my career told me that I will never forget this, that maybe you're not cut out to be a nurse. They were right. I wasn't cut out to be just a nurse. I was cut out to be a nurse, a scientist, a researcher, a policymaker, the Deputy Surgeon General, the Acting Surgeon General, and the Principal Deputy Assistant Secretary for Health. That's what I was cut out for. And you too. And I don't apologize for being a nurse, ever. And I said, well, you should have asked a nurse. And oftentimes, I have to gauge the room a little bit because sometimes I'm the only nurse, the only woman, the only person of color, the only clinician, or the only person in uniform. And this happens all the time. But it's okay, because you know what? What doesn't kill you does make you stronger. I wouldn't encourage you to do some of the things that I've done in my career. I've had to take my lumps sometimes, but it has made me stronger as a leader. It has made me more compassionate towards people. Every opportunity that comes your way brings you something to learn. I had some very interesting, I won't call them bad, some very interesting and challenging bosses sometimes. What they taught me was how not to treat people. I'm very, very careful how I treat the people that I work with. And I try to respect everyone's opinion. There are sometimes I have to just say, no, we're not doing that, but I try to hear them out first. If we don't agree, I often tell them why I don't agree. I usually try to do that. I've got this one colleague, boy, she's a nurse too, but she's a psych nurse. Psych nurses have some special perspectives on things. I love them, And she knows that she and I are usually going to be in these two camps. And I said, that's very true. However, from a financial perspective, we can't do that, and this is what we're going to do. And she usually goes, but listen to me. I said, I hear you, and we move forward. And then when something unfolds as we continue to go down the pathway, she goes, now I see what you were talking about. I said, yes, because the policy, the legislation, the clinical application, the management, the leadership all have to come through my brain at warp speed. And after having gone through some interesting times, challenging times, you develop muscle memory around that. You're able to think on your feet. You're able to make decisions faster, not too fast. And always never be too haughty to say you're sorry. When you make a mistake, own it. Because every day, and pardon me, gentlemen, but every day you have to get up, ladies, and put on your big girl panties and go to work. Because it's important for you to understand that you have to make decisions. But make decisions that are informed, that are well-founded, and that will serve best not only you, but those that you serve. That's my soapbox for leadership in a nutshell. Yes, ma'am.
I'm a first-year PhD student, and my interest is in obesity prevention in young veterans specifically. I'm hoping to catch that first 5 years of transition. Anyways, any words of wisdom from your perspective, or from the Hill, or from any I don't know.
First of all, congratulations on starting that wonderful journey of PhD. Good for you. Secondly, thank you for your interest in veterans. You're absolutely right. This is a challenging time. Many of them have comorbidities associated with depression and so forth. The best thing to do is create a partnership where you can find the captive audience. And I wouldn't necessarily say that the VA is the best place to go to get them. You need to work with some folks who are doing transition with the active duty component or the reserve component. Because you have the active duty component who are doing their day job every day, but then you have reservists who also leave that reserve environment. And I can get you in touch with some folks who do transition coordination at DOD. The Defense Health Agency is where a lot of the health components are. And we have a nurse who's a Surgeon General of the Air Force. Dorothy Hogg is the Surgeon General of the Air Force nurse. And she is a good resource. But you have chief nurses of each one of the services who have a huge bandwidth and a lot of influence over the services and can tell you exactly how to go about getting the information that you need. But I'm happy to work with you and get you a point of contact. Yes, sir.
Yes, I'm LaRon Nelson, Associate Dean for Global Health and Equity here. I want to know your perspective on the relevance or acceptability of the PACE program that you described for helping to address the initiative to reduce HIV infections by in 5 years or in 10 years. It wasn't one of the examples you used when you described them, but I looked at that, which is something that is interesting to me, and thought about, can PACE be leveraged to help address that issue?
That's exactly the initiative. That's what we're standing up. So we are creating a team, teams of 3 initially, in those three areas. The PACE teams will have a coordinator, regional coordinator, and we'll have 2 staff working with those coordinators. They will be responsible for working in those regions to work with the state and the local and the county health departments, city and county health departments, to identify where they'll do a needs assessment and figure out where are you not able to reach these individuals. Our goal is to select PACE members and leadership that will be able to engage with the leadership in the regions and develop programs through the community health centers, maternal child health programs, and also the SAMHSA, Substance Abuse Mental Health Services Administration programs, to then go into the community, go to the barbershops, the laundromats, the car dealerships, wherever, shooting galleries, nightclubs, like we did in the old days. But wherever there is a need and there's a population that can't be reached, because we're trying to target men who have sex with men and minority populations in the Southeast and in Texas, because we've not been able to infiltrate that population. We've not been able to get them in. We've not been able to have them come into care routinely and have that retention in care. So we have to figure out what needs to happen there. Each of these models will be different, but those PACE teams will be invested in serving on the HIV program and the opioid program primarily, but we're also doing vaccines as with HIV, substance use with HIV, because all these comorbidities for underserved populations, high-risk populations, all live in the same universe. So it is a public health approach focused on those first 2 high priorities, so opioids and HIV. So I hope I can come back and tell you that PACE has been successful in being able to help to lead in an area where those health departments have been able to document decrease in new infections.
And that was in LA, Dallas, and Atlanta?
That is correct. Yeah, that's where we're starting initially. So there'll be a 3-year project, and then based on the results of the first 3 years, we'll determine whether or not we will continue to have those programs funded. I think we will, because I think there's high need in all of at least 8 of the 10 regions right now around HIV, but we'll see. Yes, sir.
So I guess I'm also a first-year PhD student studying HIV and substance use, and previously worked as an HIV nurse. So I think downstream I benefited from your leadership in my previous job. I had a question about, so there seems this really robust set of outreach to different regions of the countries, and to state departments and local health departments in the Hill. But the structural conditions for both implementation of policy and a lot of the policy that's developed comes out of state legislatures, which are generally both sort of understaffed and have part-time jobs. And, we saw, for example, in Portland and in Washington, that there were state laws on the books and from legislators who wasn't educated. Is there any kind of program in this outreach to educate state legislators beyond just the county health department, but the funders themselves?
Yes, that is exactly what the PACE division coordinator will be doing. They'll be looking, so we're working across the entire department. These individuals, most of them have history of working with multiple agencies within HHS and outside of HHS. So I'll give you one example. There's one individual that I know of. He's worked at HRSA, he's worked at NIH, he's worked at CDC. So he has relationships with all of those folks. So he knows care delivery, knows the epidemiology team. Gather that data, build a white paper, and pass it off to the state legislators to say, here is information for your benefit. Now, what they do is within the regions are managed by the regional directors, which is a political, and they have a list of priorities that they focus on based off of the department and other parts of the government. But what is not said is that they also act as advisors to the state legislatures and the governor's office. So depending on the relationships between the regional offices and the legislators or the governor's office, they can or they may not have as much influence. But I will tell you what, the health departments do listen to the regional health administrators, which are OASH. They report to the assistant secretary. Actually, they report to me, but forgot that. They report to me, and we strategize off of how to best engage with the stakeholders, the advocacy and education groups, and what are the major priorities in a given jurisdiction based off of the data that we have. Now, the EPI profiles that are produced by CDC give you a whole host of scenarios that you can choose to play out in a given community. What's happening right now in Atlanta is that we have individuals who are at high risk for, eligible for certain services, but may not even know they're eligible for services. So I want the PACE team that goes to Atlanta to look at all the CDC data, look at the SAMHSA data, look at the HRSA data, and just do an amalgamation of basically overlay all these maps and look at where are the new infections, where are the points of entry, and then who are the stakeholders that have access to that population. And for a lot of these communities, it's the faith-based community. So I need people who can go and talk to the faith-based leaders who have contacts in the legislature, who have contacts in the health department to pull everyone together. They won't be the conveners per se, but they'll definitely be the innovators, providing information and supplying ideas and helping them to write the proposals for policy change. Very powerful position. I mean, these PACE coordinators can really change the map, and that's the goal, is to help individuals who don't know where there are pockets of funds to match their need, to match the community's demand. Then we can start to pull all these programs together and hopefully make some changes. But, yes, sir. Last question.
From the School of Public Health. We have 44 million Americans who live in counties that do not have adequate primary care practitioners, and it's estimated over 15,000 physicians would be needed to fill that gap, and that's not going to happen. Could you comment on how nurse practitioners could be, should be, might be deployed to address this this acute shortage of primary care practitioners in such a vast swath of the United States?
I'm glad you asked that question, because this is something that Secretary Azar met with all of the non-physician direct providers last fall. I had the privilege of being in that room, and I heard him say, one of the things I want to accomplish in my time here is to look at innovative ways to encourage the states to expand their thinking around using nurse practitioners, PAs. It's basically the military model of care. I mean, we use corpsmen, we use nurse practitioners. Nurse practitioners run clinics. I was in 03 running the outpatient clinic, and you have providers, you manage the staff that you have. Telehealth was something they talked about, but what he said but didn't say was that we hold the purse strings, and let's see how much reimbursement and system redesign can be configured to better encourage states to look at scope of practice, look at prescription privileges, look at zoning for high risk types of activities such as HIV, infectious diseases, as well as comorbidities associated with some of the high priorities of opioids and TB. I think reimbursement is how he's going to approach it, because that does send demand signals to the AMA and AAMC. So he's full on. I've been really shocked to hear some of the conversations at this level that I didn't even know were even on the agenda. But definitely scope of practice and looking at task shifting. I know you told me this is my last question. I make this comment. What we did in Liberia and what we did in West Africa with Ebola was phenomenal, but it was because we let the people who knew what they were doing do what they were supposed to do, and we got out of their way. What we did in PEPFAR, in Malawi, Tanzania, Mozambique, and DRC, Democratic Republic of Congo, who's having an Ebola outbreak right now. What we did there was that we did a lot of task shifting. We stopped nurses from doing blood pressures and vitals for screening and triage. We did not let them go get medical records. We had volunteers from the community health workers did all the outreach. And we shifted the clinic model completely around to make sure that, and this wasn't just us, it was having the providers in the community, the providers in the clinic, and volunteers from WHO help us to redesign this model so that we weren't only able to see 80 patients a day, we were able to move to seeing 200 patients a day. And one small rural clinic, which is phenomenal. I mean, at 6 o'clock in the morning, you've got 50 people lined up for care. By 7 o'clock, you've got 150 in the queue. So if you change the model, routine care done by nurses who have been trained in prescribing, you had their labs that were made available to them. You had community health workers coming in to do the labs and get all the charts ready in the morning. They briefed out to the providers what was needed, and it was a well-oiled machine. If you ever get a chance to go to Malawi, go by Lighthouse, and you can see that model in action. But that's what we need in rural communities. That's what we need in a lot of urban communities, is having a task-shifting approach to looking at what are nurses trained to do? What are nursing assistants trained to do? What are physicians trained to do? What are pharmacists trained to do? Get out of their way and let them do their work. And stop looking at this as a capitalist model. This is not a capitalist model. This is a healthcare delivery model that we need to build that will best meet the public health as well as the tertiary healthcare needs of the patients that we serve. And I think I'm getting the look. Okay.